So this lecture is about psychoactive drugs. Now, when I talk about psychoactive drugs, these can be things like recreational drugs, such as alcohol, nicotine, magic mushrooms, cocaine, cannabis, or prescription drugs. These are things like Prozac as an antidepressant or Ritalin. These are just drugs or medications that are affecting the nervous system. Now let's start off with a few statistics. So there are more deaths and disabilities each year in the U.S. from substance abuse than from any other cause. So this is a very serious issue when it comes to not only medicine, but psychology and treatment. In 2002, about 48.7 million people had a diagnosable substance use disorder. That's a problem with some kind of psychoactive drug. About 29 million people, alcohol use disorder in 2023. This is a particular problem with alcohol. And 168.7 million use tobacco. Now, alcohol and tobacco cause more deaths than any other drugs combined. Now, we've had also what's known as an opioid epidemic or opioid crisis. So in 2022, 84,000 people had opioid-related overdoses. Now, this has dropped a little bit in 2023, so those are some good signs, but it's really the first decrease that we've seen, but this is a serious problem. We'll talk about that history in just a moment. So in terms of visiting to emergency rooms, you can see that the number per 100,000 people is very high. Very high for alcohol. Alcohol is really bad, but we also see cocaine, especially for people over the age of 21. Others, less so, right? So we don't see as often hospitals visits for like hallucinogens. And this is the average cost to our medical care system for each type of drug. And again, alcohol and tobacco are the highest, right? Not only does alcohol lead to things like car accidents, but it is really bad for our health, right? It affects our liver, it affects our heart. Same with tobacco. Less so for some of these other ones. This is one of the reasons that this rather famous study came out in 2012 by Nutt et al. And what the authors did was they surveyed psychiatrists to ask them about how harmful these different types of drugs are. Harm to the user in blue, and then harm to others or harm to society. And you can see the legal drug of alcohol was ranked much higher than any of the other drugs, right? Alcohol is a real bad one in terms of abuse, withdrawal, and damage to the body. Then we get heroin and it goes down, and we finally at the end here, we're getting into the hallucinogens and the psychedelics. We also know that our criminal justice system is highly affected by drugs and drug use. At 531 prisoners per 100,000, the U.S. has the highest rate of prisoners in the world. More than half of American federal inmates are in prison because of drug-related crimes. This has a lot to do with our judicial system in that we start seeing this real focus on criminalizing drug and drug possession and drug use, and then we see right after that really big push in the early 1970s, we really see an increase in the rates of incarceration. So let's talk about some recreational drugs. Usually we use the word recreational drugs. These can be legal or illegal, sometimes called illicit. These are taken for pleasure, for stimulation, relaxation, to alter consciousness. Some of them are legal, like alcohol, nicotine, cannabis in some areas, and even psychedelics like psilocybin in some areas. Some are illegal, like cocaine and heroin. And some are taken, they can be prescribed legally like OxyContin, or they can be sold and taken illegally like you see today. Some are illegal, like cocaine, methamphetamine, and heroin. Some are legally when they're prescribed, like OxyContin, which is an analgesic, it reduces pain, but they're also sold illegally. Same with things like ketamine. Ketamine is a very often used drug for anesthesiology, but it's also sold illegally as an hallucinogen. So, substance use disorder is the clinical term for when somebody has a problem with drug use. Drug use to the point that it causes harm, that it's repetitive, that it's compulsive in somebody needing to take it. Recreational drugs can be addictive, can form substance use disorder, especially those that are dopamine agonists, that increase dopamine, especially in the mesolimbic dopamine system. We'll get to that in another lecture. So let's go through some of these and a little bit about their action. Very brief. So alcohol, one of the most common, legal, it's an psychoactive drug. It affects the nervous system like all the others. Even though it's legal and people are often shown having fun with them on commercials, this is a psychoactive drug like any other drug. Sometimes it's called ethanol. These are GABA agonists. And you can see here that a GABA receptor actually has a place for ethanol to activate it. GABA is the number one inhibitory neurotransmitter, and GABA can inhibit things like glutamate. Glutamate is necessary to form memories, and that's why drinking alcohol can lead to memory loss. Alcohol also affects dopamine indirectly. It affects things that might inhibit that which inhibits dopamine, and therefore dopamine increases when alcohol is taken. Now, alcohol produces some of the worst withdrawals of any psychoactive drug, right? Heroin is bad, opioids are bad, but alcohol is worse. What we have is called alcohol withdrawal syndrome. And it goes through these stages that can last up to several days. And people can show hallucinations, can go have seizures, up and down temperature, really get sick. And in fact, if somebody has a severe alcohol addiction and they go through withdrawal, they need to seek medical help because people die from going through withdrawal. This can happen if people aren't given treatment. Another bad thing about alcohol is that each time you withdraw, the symptoms are worse. So somebody who is addicted to alcohol use disorder, and they withdraw, and then they relapse and they drink again, and then they withdraw. Each time it's worse. We call that a kindling effect or kindling. Okay, now nicotine, another extremely commonly used psychoactive drug. This works on several systems. In fact, acetylcholine as a neurotransmitter has several types of receptors. It has muscarinic and nicotinic receptors, which nicotine affects. Nicotine also is a direct dopamine agonist, meaning it increases dopamine. And it gets to the mesolimbic dopamine system very quickly when it's smoked or vaped, right? So it can be highly addictive. In fact, nicotine can often be rated as the most addictive drug. And another statistic that we see is people might have an addiction to cocaine or an opioid, and they're able to get off in their late 20s or 30s. Nicotine isn't one of those kinds of drugs that are easy to get off. It's very difficult, and the addiction can last an extremely long time, even if somebody has not had cigarettes or nicotine for a while. That relapse is very common. What we've seen lately, though, is a decrease in cigarette use. which is a really good thing. Lots of advertisements, lots of information has reduced cigarette smoking. But what we've seen is an increase in vaping, right? Where there's steam created from a nicotine product. And these are highly marketed and valued to children. Now, here's a rule about addiction that we'll talk about in another lecture. Addiction is oftentimes thought of as a developmental disorder. Why? Because we see addiction really beginning in early to mid-adolescence. People rarely begin addictions later in life. Now, the vaping phenomenon has marketed to kids using flavors that are very valuable to kids, highly sweet candy or Fruit Loops or things like that, which is valuable. We can see that there's been a really big increase in vaping. There's been a lot of research on vaping lately. I mean, the idea is, vaping is less harmful than nicotine, right? Nicotine is linked to all sorts of problems, cancer and heart disease and kidney problems and all these kinds of things. And the question is, vaping doesn't do that. And that's not true. Vaping is linked to heart disease and a lot of other problems. Another thing is we don't really know real well what is in these products. And these are highly addictive, and they may be just as harmful as cigarettes, not to mention the fact that people who vape oftentimes increase the amount of vaping they do because they might show some tolerance to it and oftentimes may then lead to cigarette smoking. There's been a number of studies of whether vaping is a way to get off of cigarette smoking, and the results of that have been really mixed. It doesn't prove to be a really good method. Okay, now we get into the psychostimulants. They stimulate the brain. These are often direct dopamine agonists. These are things like cocaine, crack cocaine, amphetamine, methamphetamine, and prescription drugs that are often prescribed for people with attention deficit hyperactivity disorder, ADHD, like Ritalin or Adderall. These are dopamine agonists and they can be highly addictive. One problem is that we've seen this increase in overdoses that are linked to psychostimulants, like, for example, methamphetamine. We see the increase in overdoses that's happened. Now, these are oftentimes in conjunction with opioids. People are taking a psychostimulant with an opioid. An opioid is going to depress our ability to breathe, and a psychostimulant is going to increase our need for breathing because our heart rates are elevated. Those two things do not work well together, and people are overdosing. Now, stimulants like this, psychostimulants, I said are dopamine agonists. They tend to be dopamine reuptake inhibitors. They stop dopamine from coming back in the presynaptic cell. Things like methamphetamine actually go into the presynaptic cell and cause the release of neurotransmitters out of the vesicles directly. So Adderall and Ritalin are very commonly prescribed medications. Adderall is just a type of amphetamine. Ritalin, these are both dopamine reuptake inhibitors. They are prescribed for people with ADHD and can be very effective for people who are diagnosed with this disorder. It seems kind of odd that somebody who has hyperactivity in the name of their disorder is getting a psychostimulant. But these are activating dopamine areas in the brain whose job it is to inhibit things that are happening, let's say at the thalamus, inhibit extraneous stimulus and help people focus. Again, these are reuptake inhibitors. They can increase a lot of function of the frontal lobe, which is executive functions like planning, organizing, and attention. Adderall acts a little slower, but the effects last longer than Ritalin. A number of people take Adderall and Ritalin without prescriptions, right, illegally, especially people maybe in college, because they think it's acting as a neurotropic, which means a smart drug. It's helping people to learn more, to have greater attention. There's been a lot of research on this. And while in laboratory settings, And using tasks that acquire selective attention, people can show slight improvements in labs, in research, with Adderall and Ritalin. However, lots of research has been done on people who use this to improve grades, these more global ideas of studying, and that keeps coming up negative, that we're not seeing that Adderall and Ritalin are really helping like people think they are. Not to mention, as with most psychostimulants, they are going to affect sleep. And people who are taking psychostimulants like cocaine, methamphetamine have terrible sleep problems, but also Adderall and Ritalin can affect sleep. One of the most important things in getting good grades and studying and retaining information and memory is a good night's sleep. So there's this really balance there, this trade-off. There's not a lot of evidence that this is really helping studying, and it actually can hurt by affecting sleep. So remember, lack of sleep is going to worsen attention, worsen cognition, and worsen memory consolidation. Okay, now we get to the opioids, which has such an interesting history to talk about. Opioids are analgesics, right? As one of the things that they do, they reduce pain. And these are wonderful, wonderful drugs for people with chronic pain or who have experienced pain. So we can't just say all opioids are bad. And in fact, what we see, opioids started to show up in the Civil War when people are getting their arms cut off and all this stuff in surgery, and we're using opiates. Opiates are naturally derived from poppies like morphine, and this is really helping a lot of people. So we use opioids if it's synthetic, and opiates if it's natural. We see opioids like fentanyl and OxyContin can be really, really dangerous if not used properly. So people who are going through cancer treatment, people with severe burns, people who are end of life, they're getting some of these drugs like a fentanyl patch, and it is really a great thing. However, fentanyl and OxyContin you can overdose really easily on them, like especially fentanyl, which is a new class of synthetic drugs. Heroin has a kind of an interesting story because people think of heroin as an illicit drug, illegal drug. And it was actually legal for a long time. It was created by the Bayer Corporation. Remember Bayer aspirin? And they said, this drug is so great, we'll call it the hero of drugs. Heroin means hero. And what it was proposed to do was stop people coming out of the Civil War who had addictions to morphine. They said, okay, here's heroin. Heroin, you don't form addictions to heroin. And they started sending this out as free samples to a lot of people. So making the claim that you can take this analgesic, but you won't get addicted to it like morphine. Of course, that's not true at all. You even see things like Mrs. Winslow's soothing syrup, which had basically heroin in it, given to children who are teething, children with colic, children who are having a hard time sleeping. Give them a little bit of an opioid, they go right to sleep. And this was really marketed a lot until we started seeing people showing addictions, and then it was made illegal. And then we get into the 1990s, and heroin addiction is bad, as it had been. And so a company, Purdue Pharma, said, okay, we have it. We have an opioid that is non-addictive. Just like Bayer said back with heroin. Why is it not addictive? Because it's time released and it can be used to treat chronic pain and cancer pain. And it was really heavily marketed. And the issue with this, though, is people were taking higher and higher doses. There was such a big push to get doctors to prescribe it. Now, not all doctors were doing it, but a selective few were really pumping this stuff out. And if you wanted the effects to happen quicker, you just simply crushed up the pill, and you would lose that kind of time release ability. Is OxyContin addictive? Yes, it is, just like heroin, right? So they were Purdue Pharma, Johnson & Johnson, they were lying as well. And what happened was they would get these prescriptions. People would have maybe a back injury or something. They get these prescriptions. They would start forming addictions, and then the doctors would cut them off, and then they would move towards taking things illegally. One of the things that influences addiction is uncertainty of getting a dopamine increase. And as you move into getting your drug illegally, that's just fostering that addiction, because the drug that you're getting is showing greater variability in its content. So what you see happening in the early 2000s and the mid 2000 teens is you see these things called pill mills or pain clinics set up. People would line up and doctors would just be prescribing these things. You'd come in, you'd say, oh, my back hurts. Here, take OxyContin, and then come back and take more and more and more. And people were making millions and millions of, literally billions of dollars off this stuff, but it really pushed the increase in addiction. Opioids are affecting many areas of the body. They are increasing dopamine as well. So what we see is these reps going around and having these and sending doctors to these getaways down in the Caribbean and giving them all this money and giving them all these swags. Hey, take OxyContin. Look at this fun pill. Here's a little koala bear that's telling you to prescribe OxyContin. And they would tell the doctors, hey, this is a great way to manage pain in your patients, and it is non-addictive. And they were lying. And you see tons and tons of lawsuits since then. When I'm making this lecture, I found an article saying that almost 3,000 cases against Purdue Pharma, they still were not criminally liable. That still might be pending. They lost a lot of money, but they made a lot more money than they lost in these lawsuits. This company really made a ton of money off of promoting a United States and global pandemic of addiction. You see that addiction rates, death rates because of opioids were rather low. Here's the kind of rule. People do overdose from heroin. It happens. But it is not as common as it is today. It is not common for people to overdose with heroin. But people with synthetic drugs, such as fentanyl, the rule is overdose. The rule is that people with these synthetic opioids, they're going to overdose really often because fentanyl has such a stronger affinity to opioid receptors. So what is this doing in the brain? Well, we have our own endogenous opiate system. We have opiates in our brain. And poppies can make a similar chemical, or we can synthetically make them. There are 3 types of opioid receptors, mu, delta, and kappa. Most of these illicit drugs are acting on the mu receptors. They're involved in many areas of the body and the brain. They help reduce pain. So if you amplify these, you give an agonist, something that is increasing or acting like one of these, our own opiates, we're going to reduce pain. It affects areas of the brainstem called the periaqueductal gray and the ventral medial medulla. These are all areas that are receiving information about pain from the body. But these are also areas that are involved in something else, which is breathing, regulating breathing. So if you are adding too much to this system, you're going to stop regulating your breathing. People are going to die from not breathing. They can also be highly motivating because they are indirectly increasing dopamine in the mesolimbic system. So here are all the different areas that we see the mu opioid receptors, right? So we're seeing it up in the cortex, in the brainstem, in the ventral PAG, periaqueductal gray, the dorsal horn of the spinal cord, all it regulating and helping with pain. Again, I want to point out that opioids, even fentanyl, are really miracle drugs. They're really good for people who experience chronic pain. People who have a great deal of pain, especially during the end of their life, This is horrible and this is miserable. And if a doctor prescribes in the right way these medications, these are good for those people. The problem is that they are also highly addictive and are taken illegally. And as we saw between about 1998 and all the way up to about 2016, they were overprescribed. So now we come to fentanyl, right? Fentanyl has a really strong affinity or effectiveness on receptors, more so than any. And it doesn't take a lot of fentanyl to cause the overdose in the brainstem, right? Cause the bruising overdose. You don't see this with heroin and morphine. So even this tiny little bit of fentanyl can cause an overdose. And fentanyl is starting to show up because it's also very highly addictive in other drugs like cannabis and like ecstasy pills and like other pills. So you don't even know you're taking fentanyl. And if you have no tolerance for it and you take too much because it's not really regulated by the illegal drug trade, we're getting a lot of these overdoses, not because somebody's taking fentanyl, certainly that happens, but because they think they're taking some other type of recreational drug. And then we lead to what's called naloxone, which is Narcan. This also has a great affinity towards opioid receptors, but it doesn't activate them, it only blocks them. And it actually can kick out opioids like fentanyl from the receptors. It was estimated that between 2017 and 2024, over 100,000 people lives were saved because of naloxone. You can buy Narcan. There are several clinics that give them away for free. You can go to a pharmacy, at least in California, and you can get these for about $30. Keep in your refrigerator, they can last a bit of time. If you come across somebody who you think is overdosing, right, you give them a spray of this into their nose, and if they are not overdosing, this isn't going to kill them. It's just simply going to block all their opioid receptors for a little while and kick out those drugs like fentanyl. So it comes in, naloxone comes into the receptor and will kick out other drugs. Now here's something to keep in mind. The other drugs like fentanyl will stick around for a while in the system, and naloxone won't stay as long. So somebody can have a fentanyl overdose, they get naloxone, they come to, you've saved their life, but it might be a half an hour later, even without taking another drug, or an hour later, they could overdose again because the naloxone is gone. This is one of the reasons that if anybody gets a naloxone spray because they think they're overdosing, they need to go to the emergency room. You need to call an ambulance, right? Another thing that happens with naloxone is as soon as somebody takes it and then they come to, they go through withdrawals very quickly because basically their whole opioid system isn't working very well. And they're going to be feeling a lot of pain and they're going to have a really strong desire to get more opioids. Some things to think about. Again, miracle drug, but there are some things to be concerned about when administering it. Not in the health of the person because of naloxone, but what could happen after. Okay, now let's talk about a really interesting type of psychoactive drug called hallucinogens or psychedelics. These change consciousness. They can produce changes to moods and perception, to the sense of self, right? And these include psychedelics and what are called dissociative hallucinogens. Sometimes people don't put the psychedelics under the class of hallucinogens because psychedelics oftentimes don't produce visual or auditory hallucinations. They do produce changes in consciousness. So psychedelics, this is like magic mushrooms or psilocybin, mescaline, LSD, MDMA. They can produce a sense of euphoria, visual and auditory hallucinations sometimes. What's called ego disillusion, which is the sense of not being part of seeing yourself from the outside, losing a sense of self. These don't increase dopamine. They tend not to be addictive. They tend to have really low risk for addiction. The They're mostly activated on serotonin receptors, not dopamine receptors, specifically serotonin 5-HT2A receptors. In the whole category of dangers, these are really ranked low. People who have take a psychedelic in a safe environment with people there oftentimes say that they have a very good experience, and yet they don't say, well, I want to do this every day. Doesn't mean that there aren't some concerns and dangers that go along with this. People can have bad experiences, especially if they're doing it by themselves or in unfamiliar environments or without somebody there. We oftentimes talk about set and setting when it comes to a hallucinogenic experience, what you're bringing to it, the set, your mindset coming in, and the setting. Is it a good environment to be? Is it a safe environment? Are there other people there that can help you? The dissociative hallucinogens, they're acting on other systems. They're acting on glutamate system stuff. This is like ketamine, PCP. These can be a little bit more dangerous for sure, right? Ketamine is an often used anesthetic. It can cause respiratory problems. It can interact with other drugs. If you remember the star Matthew Perry from the show Friends, he likely died because of ketamine use. These also can produce ego dissolutions, and these sort of have a much higher risk than psychedelics. So if we look at it like LSD, and this is one way of thinking about those experiences, it's very hard to really differentiate between the different experiences. This kind of graph is sometimes used, right? Ego dissolution with LSD, a little bit, much more a synesthesia, which is music or sounds producing colors, changes in perception, loss of anxiety. We tend to see loss of anxiety with this, right? Again, these can be good experiences under the right conditions. If you're really interested in this, there's a number of good books out there. And so Michael Pollan wrote a really good book called How to Change Your Mind. This is about the history of hallucinogens. It's also about the new research and renaissance in research on the use of hallucinogens in treatment. Michael Pollan's a very good author. He's written a number of books on food and gardening and other things. He's a professor at Berkeley. What was really interesting and enjoyable about this book, I thought, was the fact that he took all these drugs. He tried them all and not only talked about their history and how they affect the brain and what they do, but talked about his personal experience. And here's a college professor who hadn't had a lot of experience with this. And so he experimented with LSD and magic mushrooms. They tended to be positive. He did something where he licked a toad, which has a very strong hallucinogen. Didn't really like that experience. This was also made into a Netflix documentary, which is also very good if you don't want to read the book. There's been a number of studies on the effect of the brain, what's happening in the brain. I love this kind of graph. This showed up in an article about looking at functional MRI with somebody taking LSD. And what we're seeing is these circles here are kind of representing different areas of the brain that are interconnected. And LSD just increases connectivity in terms of activation of different areas of the brain. This is probably producing that synesthesia, that sound and color and those experiences all together. Here's another kind LSD and MRI study, and it just looked at how the brain, all areas of the brain kind of are active together. The history of psychedelics is so interesting, and what we're seeing lately, there's a renaissance in research is interesting too. So, a guy named Albert Hofmann was a chemist, and he accidentally was looking at chemicals from a specific kind of fungus, got some on his fingers, and didn't feel well. Something was odd. and he got on his bike and he rode home, and he thought he was going to die because he's just all these colors and all these things, all these changes in his idea. And he went home and he laid down and he just thought, oh, I got exposed to a drug. This is not good. I'm going to die. And what he came across was just LSD. And he's known as the inventor of LSD. And in fact, on April 19th is the unofficial bicycle day for LSD, right? Because in 1943, Albert Hoffman was riding his bike and seeing all these strange visual and auditory stimulations because he accidentally exposed himself to this. But there was some research on this, but this research started getting out of hand with people like Timothy Leary telling all of his students to take LSD, and this is the time of the Vietnam War, and it was hard to recruit young men to go fight in a war when their brain is connected to the whole universe because they're having these LSD trips. And so what you see at the beginning of the 1970s is the classification of hallucinogens like LSD and psilocybin, and they were classified as Schedule 1 drugs. And a Schedule 1 drug, by definition, has no current applicable medical use at all. Highly potential for abuse, real bad. In other words, you can't do research with it. So while there was all this research, good and bad, happening with LSD and other psychedelics in the 1950s and 60s, that all stopped in the 1970s. And it's a little too bad because there could have been some good work done. And it wasn't until very recently, maybe 20 years ago, that we start seeing this new kind of research with the psychedelics. And there has been a number of really interesting papers coming out lately on the possible efficacy of using these drugs under the right circumstances to treat people with depression and anxiety and substance use disorder. This is a very famous study in this. 51 terminal cancer patients. These are people who have tremendous depression and anxiety because they're dying. And they were given one treatment of psilocybin, and they showed this large decrease in their symptoms, and these lasted for a long time. So this wasn't an ongoing thing. Like if you take an antidepressant, you're going to take that antidepressant every day. This is a one-off kind of thing, or one or two. And this is randomized, double-blind. The thing is that when doing research on the effectiveness of psychoactive drugs, there are protocols, and these protocols can be very difficult to follow when you're doing something with something like a psychedelic. If you take an antidepressant, you're doing some research, you might have some patients take the antidepressant you're researching, and some take placebo, which is a drug that has no active ingredient in it, right? It's like a sugar pill. They look the same. The researcher who is giving the pills out don't know which one's which, right? This is all on a spreadsheet somewhere. The participant doesn't know whether they're getting the placebo or the active antidepressant. That's called double blind. The researcher's blind to who's getting what, and the participant is blind, double blind. Well, this can be difficult with psychedelics because if you give somebody a sugar pill and you say, hey, we're giving you a psychedelic or possibly to help you with depression, and you're giving somebody else a magic mushrooms, they know which one they got, right? Because suddenly you are having all these very psychedelic experiences. So that can be difficult in this type of research. They're trying to overcome these kinds of things. Also, remember about set and setting? A lot of the efficacy of these kinds of drugs are because they're getting therapy along with them. They're getting guided through their psychedelic trips. And they are in good environments. I mean, if you're taking an antidepressant, you go home, you pop the pill in your mouth, and take a drink of water. With these, you're put in environments with guides, with music, and in really nice environments. That is important in the efficacy. So here's another one, the effects of psilocybin. on major depressive disorder, right? And rapid improvement, depression in improvement for 4 weeks. This was a good recent study showing that it might be helping people with depression. Now, what I want to say here that's very clear, I'm trying to make this point, is this isn't like I have depression, so I'm going to go and take magic mushrooms, right? Again, the therapy, the setting, professionals being with you when you're doing it, those kinds of things can be extremely important on whether this is helping with those symptoms. Here's another study, that looked at depression symptoms. This is pre-treatment. This is the level. And they take the drug right here and they look to see how long it lasts. Again, this isn't repeated use medication. This is one-off medication or maybe one or two experiences. Right now, ketamine is the only one that is legal to use in treatment for depression. And in that case, it's because you're having an anesthesiologist administer it. And a lot of people think, okay, that might be good, but maybe some of these other psychedelics might be better. Lots of legislation going out right now for ecstasy, MDMA, on its treatment for PTSD, and psilocybin and LSD for treatment of all sorts of psychological disorders. As I'm making this lecture, I'm thinking, well, in a few years, this lecture is going to be irrelevant because I think there's going to be a lot more legal treatments. So here's that really good research being done with MDMA, assisted therapy for people with PTSD. I mean, you have to understand that in 2021, study estimated that 4 times as many active service members and veterans die by suicide as died in battles since 9/11, right? So in other words, many people who are actively in battle, who maybe have had traumatic brain injury, or maybe not, maybe they work in a silo in Nevada flying drones across the world, whatever. We have a really bad problem with not only PTSD, post-traumatic stress disorder, depression, anxiety. In the military, there seems to be some evidence that assisted MDMA treatment work for some people, not for everybody. So we're mostly seeing the use of these psychedelics. First of all, they're still just clinical trials. They tend to be focused on people who are treatment resistant. Antidepressants aren't working. Cognitive behavioral therapy isn't working. Maybe this is an alternative. I wouldn't be surprised if these are more common ways of treating disorders, anxiety disorders, generalized anxiety disorders, PTSD, phobias, things like that, major depressive disorders, and substance use disorder. Okay, now we get to cannabis, and cannabis is kind of an interesting thing too because it's kind of a mixed bag here. So cannabis is derived from cannabis plants. There's 2 main ingredients, though there are lots and lots of ingredients in these plants, right? There's THC. The THC levels are most associated with the euphoria or high that one feels. Plants are bred for different strengths of THC. And then you have the cannabinoids, the CBD, most associated with relaxation and pain relief and things like that. The cannabinoid system in the brain that this is activating on plays a role in hunger and food. This is one of the reasons that people who use cannabis oftentimes say they have the munchies. They want food. These are dopamine agonists, and they can produce cannabis use disorder, which is the habitual use to the point where it's disrupting one's life. But the cannabinoid system also is associated with feelings of pleasure. The dopamine system is not really your pleasure center necessarily. It's more of your motivation center. It's mostly, to get out and do stuff. That's why it's highly involved in addiction, because it makes you do stuff. Cannabinoids, more associated with feeling happy. A couple things to think about. One, cannabis use disorder, very common, especially as we see THC increases. This is somebody that is using it habitually. It's harming them, right? Addiction, substance use disorder, always within the context of compulsion and harm, right? If you're having a glass of wine on the weekend, or a couple beers now and then, are you addicted to alcohol? No, you're not showing those problems. Same with cannabis, having an edible now and then, or marijuana on the weekends, probably not. But if you're waking up and doing it, if you're having to do it in order to get to sleep, we're starting to get into this problem. It can also really inhibit motivation. One of the things that we see is that cannabis tends, again, adolescence, again, a developmental disorder. It can be really harmful for the developing brain. In that compulsion sense, not as bad for older adults. But there's another thing that is just shown up called cannabinoid hyperemesis syndrome, and it's something to look out for because we didn't really talk about this much anymore, and now it's kind of showing up everywhere. Because the cannabinoid system is playing a role in a lot of systems, just like all drugs are. Some people, not everybody, if they're using it a lot, using cannabis a lot, typically a lot, but not always, but typically a lot, they can start having a lot of digestive problems, a lot of stomach pains, throwing up, severe vomiting, oftentimes maybe blood in the vomit. This is linked to the fact that the cannabis that people are using today is not what it was 30 years ago. The THC is much higher. This is linked to THC. So it's one of those things where people are suddenly they're taking cannabis and everything's fine and happy, and every once in a while, by the way, this might not be a chronic thing. You might be taking a lot of cannabis, and then once every 90 days you have these really big problems. But it's often not recognized. Like, why am I having these terrible stomach problems? This might be the reason. Also, if you're taking cannabis often, and you have cannabis use disorder, when you stop, when you go, one withdrawal symptom is a real bad stomach issue. Okay, another thing to think about is in our brain we have homeostasis, right? We're trying to keep a nice balanced level of things. And so if you're taking a lot of cannabis, your own cannabinoid system is going to start decreasing, because it's saying, I've got plenty of it. And one of the things that the cannabinoid system is doing is it's having a lot to do with your ability to experience pleasure. So one symptom of chronic cannabis use is what's called anhedonia, or the inability or lack of strong feelings of positive emotions. You might feel really happy when you're taking the cannabis, but other parts of your life might be not as happy, not right. So there's been some interesting research on this. We see this with all types of drugs. Take opioids a lot, your own opiate system is going to decrease. It's one of the reasons why when you stop taking an opioid, you're going to be feeling pain, because your own opiate system, which regulates pain, is not functioning. Right? Hypofunctioning or deregulating or downregulating. Same with cannabinoid systems. So again, this is one of those kind of gray areas. Having cannabis now and then with some friends, probably not going to be very harmful. Doing it every single day, you're going to have not only maybe digestive problems, you're going to have motivation problems, but you might also start having less pleasure in your life. So here's some of the benefits. Again, we're still doing research in this area, because the research on cannabis, again, this was a Schedule 1 narcotic for a very long time, so the research is new. May help people who are going through chemotherapy to increase their appetite, reduce nausea. In some cases, it may reduce cancer tumors. May help some people with anxiety and depression. Schizophrenia, PTSD, some it helps, some it doesn't, some it makes worse. That's another thing to think about with psychedelics, right? Psychedelics, if somebody has severe schizophrenia, this is not really the drugs they should be doing. There is some forms of CBDs that may help with a special type of epilepsy, a seizure disorder in children. May, in some cases, reduce opioid use and overdose. People are using this. They're not taking as much opioid. There's some statistics there. With sleep, it's a weird thing. There's lots of research lately on this with sleep. So people with insomnia, people with difficulty sleeping, this might be helpful, especially the indica variety of cannabis. Sometimes it's called indicouch because you just want to sleep, and, a small amount might help them. It is going to reduce REM sleep, and we need our REM sleep. And so that's not so good. We have a lot of REM in the morning, and so cannabis tends to peak after about an hour and then kind of decreases up to 4 or 5 hours after that. So you still might be able to get some REM in the morning, but you're not going to get the REM that you normally get. One of the things that we see with people with withdrawal from cannabis is they oftentimes have sleep disturbances and really odd dreams. So it might help in some cases, might be harmful in others. Still, with psychedelics and cannabis, I think we're still at the very beginning of research. Might be some good stuff, but keep in mind, it's never ever only good, only bad. Okay, hope you learned a lot.